Thank you, everybody. Good to see everyone after our summer hiatus. I hope everyone had a good summer and tried to stay cool and survive the hurricanes. So here we are, and we're starting our first. Can you hear me okay? How is this? Okay, let me see if we can up this a little bit for our speakers. Thank you. Welcome everybody. It's good to see everybody back after the summer break. And we're starting tonight's this series with the program on STDs. But first, a little bit of some announcements. We've got several things coming up. Tomorrow night, Mark King, the blogger from My Fabulous Life, has a book out, and he's doing a book reading event at the Mizell tomorrow night. So please, I think we've sent it out through our emails and so forth. So thank you. People are nodding. That's good. And I'm sorry. I believe it's 6:30. Thank you. Right. So show up at 6:30 for that. And then later on this month is the Positively Aging Project on Saturday, September 23rd. I'm sure you've been seeing all the emails about that, but it's coming up quickly. We're really excited about our lineup, including Peter Staley, the noted ACT UP activist from New York, who was really instrumental in helping get the attention of the FDA and NIH on AIDS research back in the day, and befriended Tony Fauci, those many years ago, which really kind of turned the tide. So we're excited about that. He also has a book that just came out, and so he'll be talking about that. And we are providing a signed copy of his book to everyone who attends. So please come, bring a friend. Like everything we do, it will be online. So if you can't make it out of the house or you're out of town, just log in to Zoom and it will be on there. And of course, we record those for posterity afterwards. I don't believe so, no. Yeah, we're not organizing that one. That's Mark and the Mizell Center. So it's kind of a sad note. I don't know if everybody knew that Ray Bordeaux passed away a couple of months ago, very sadly. So they had a memorial service for him at the church he attends up in Yucca Valley, and scattered his ashes there. I know some of us were there for that, and it was a really touching memorial. But we'll miss him. He was a feature at all these events. He was always taking pictures, as you know. He was kind of self-appointed photographer, and I know we got lots of great photos from him from the events that we did. So 44,000 photos. Wow. I don't know if you heard that. 44,000 photos in his photo library. His friend Ken Verganet has those. So if you need any photos, they're out there for everyone's use. So with that, we'll start with tonight's program and invite our first speaker up, Trent Broadus, nurse practitioner from Desert AIDS, or DAP Health, I'm sorry. Cold habits die hard. So just use the arrow and make sure to speak into if you have any issues. And that should work. I tested it earlier. So if it doesn't, we can pull it up separately. The video.
Oh, see. Okay, thanks. Thank you for asking me to come. My name is Trent Broadus. I'm a nurse practitioner. I'm an HIV specialist, and I also am the clinical lead for the sexual wellness clinic at DAP Health, also known as the Orange Clinic, if you've never been. So we now say sexually transmitted infections, or STIs, instead of STDs, because they're not diseases, they're just infections and can be cured. So in the news lately, there's been lots of discussion and talk about, well, in my news. Oh, sorry about that. I'm going to start with a little.
Gonorrhea is a major public health concern in the United States. More than 1 million new infections occur each year, but because many people don't have symptoms, fewer than half are detected and reported to CDC.
Go ahead and pause it on me.
Untreated gonorrhea can cause serious health problems.
So I have it queued up, and what I will do
In a different way.
I want to share that one instead. So, and show. And let's find Zoom again. We'll share.
Gonorrhea is a major public health concern in the United States. More than 1 million new infections occur each year, but because many people don't have symptoms, fewer than half are detected and reported to CDC. Untreated gonorrhea can cause serious health problems. It can increase the risk of a life-threatening ectopic pregnancy, cause conditions that can lead to infertility, and increase a person's risk of getting or giving HIV. Medication to treat gonorrhea has been around for decades, but the bacteria has grown resistant to nearly every drug ever used to treat it. In the 1980s, resistance to penicillin and tetracycline grows, and they are no longer recommended to treat gonorrhea. Fluoroquinolones are the leading drugs to treat gonorrhea in the 1990s, but the bacteria was adapting to the drugs. CDC modifies treatment for much of the next decade to keep pace with resistance. In 2000, the drug is no longer recommended to treat people infected in Asia or the Pacific Islands. By 2002, this recommendation extends to California, and then in 2004, to men who have sex with men throughout the United States. By 2007, widespread fluoroquinolone resistance leaves only one class of antibiotics, cephalosporins, to treat the infection. In 2010, CDC recommends adding a second drug, either azithromycin or doxycycline, to the treatment regimen to protect cephalosporins from resistance. But just 2 years later, in 2012, CDC must update treatment recommendations again when data suggests the oral cephalosporin, cefixime, is becoming less effective at treating gonorrhea. As of 2020, CDC no longer recommends azithromycin due to emerging resistance that could threaten its ability to treat other common infections. Gonorrhea is becoming harder and harder to treat. Today, a single injection of the cephalosporin, ceftriaxone, is essentially all that stands between us and untreatable gonorrhea. Our last treatment option won't last forever. A difficult-to-treat strain of gonorrhea has been reported in the U.S., and broader surveillance shows half of all infections are resistant to at least one antibiotic. The U.S. hasn't seen a treatment failure with the recommended treatment, but drug resistance is rising, and the pipeline for new drugs isn't keeping up. Prevention, testing, and effective treatment are needed now more than ever. We must keep drug-resistant gonorrhea as a leading priority. Learn more at cdc.gov/std/gonorrhea/ARG.
Okay, well, apologies for the video, but you got the audio, so you got the message. Let's start again with the
My role at Ohio State University is both research and teaching. Ultimately, how we use
and
I
move
think
it
we're
around.
on that one right there. That's why it's oh, there's all this.
Every time they do an update, this happens. Okay. Oh, this is,
Can you hear me now? Not yet. Can you hear me now? Is it off? Hello? All right, so trust me, it was a great video.
We'll send out the link.
Yeah, it is. It really is. And it puts a great timeline on where we are with treating gonorrhea currently, which is still being treated currently with the same antibiotic called ceftriaxone or Rocephin, the 500 milligrams. But I do remember in that year around 2012 or 2013 where the CDC made a recommendation to up the dose on the same medication. So earlier in the year, there were 2 cases in the United States. So I'm on some links that give us updates on when we find resistant organisms in STIs, and there were 2 cases in Boston this year. They were eventually cured of gonorrhea, but with repetitive doses, at repetitive high doses of the same medication. So I'm going to talk to you just about gonorrhea, chlamydia, and syphilis, the triad or the 3 main STIs that we see in this area. And then Dr. Phyllis Ritchie is going to take over from there and talk about some more details in those. But first of all, let me tell you a little bit about gonorrhea. So gonorrhea and chlamydia are tested by either a urine sample or swabs. You can have gonorrhea and chlamydia in your throat, you can have it in your urethra, or you can have it in your rectum. You can have it in one of those spots, 2 of them, or all 3 of them. And so that's why it's important to test. Test. I'm constantly screaming about testing. You don't know you have it, may not know you have it until you test. So swabs of the throat, swabs of the rectum, and a urine specimen. And for some of you may remember, we used to actually put the swab in the pee hole, your urethra. That was not fun, but we found that a urine specimen is just as effective at doing a swab there. So those STIs stay at the point of contact. They don't circulate throughout your body. So if somebody has gonorrhea or chlamydia in their throat and then they perform oral sex on you, now you have it in your penis. If they put their tongue in your butt, now you've got it in your rectum. So test. Sorry if you're eating. It's a little bit too much there. Gonorrhea, typical symptoms, they vary. Not everybody responds the same or reacts the same to infection. So typical symptoms are discharge, irritation, burning when you pee, and that can be in both. You can have discharge from your rectum if you have gonorrhea in your rectum. Patients will tell me their stool is unusual, mucus, when you, with hygiene, with cleaning, irritation, pain, same with the penis, burning when you pee, discharge. So guys say, well, how do I know if it's discharge? If it looks like it's not supposed to come out like that, then something's wrong with it. If it's not your typical pre-cum, and you can't really identify it, it feels different, get tested and treated. Test. Gonorrhea, so we're still treating it. There's been no new recommendations, even though we're worried about resistance. There's no new recommendations for a change in the guidelines for treatment, but I have a feeling that's coming. Chlamydia, the sister. So chlamydia, same thing. You can have chlamydia in any site, throat, urethra, rectum, but chlamydia is a little more elusive. People can have chlamydia for years and not know. Often women do not have symptoms of chlamydia. Men may or may not have symptoms of chlamydia. And even though the text says something, it says many things, right? You can have symptoms. I'm going to tell you what I typically see. So in regards to in your urethra, it's an irritation. There's usually not much discharge. It's an itch or a scratch or even patients will tell me that it feels better after they urinate. So it sort of scratches the urethra and kind of soothes the urethra after they urinate. Chlamydia in the rectum, constipation. That's one of the symptoms that I typically see is they will complain of constipation or their bowel movements are off. It's not as wet as gonorrhea. And the important thing with chlamydia is with any STI, left untreated can cause some serious infections. And one of the problems that we have with chlamydia untreated in the rectum is infection that can move into the lymph nodes and cause very serious infections. Chlamydia is still susceptible or easily treated with the antibiotic doxycycline. 1 pill 2 times a day, morning and night for 7 days is the treatment. It's important to have if you ever have a suspicion or test positive for an STI, it's important to have your partners tested. And I'm going to just kind of tell a few little anecdotes as we go along. So I have patients that come and they say, we both have gonorrhea or we both have chlamydia, and my partner and I were both getting treatment at the same time. So it's okay for us to have sex, right? It's not. You have to remain abstinent, no sex for the full 7 days while you're on the course of antibiotics, or if it was an injection. Well, it seems like since we're both being treated that we would both be cleared at the same time. But what I tell them is there's different degrees of infection. There's a mild infection that may clear in 3 or 4 days. And then there's rip-roaring infections that may have been there for a while that are going to take the full 7 days. So you are limited to masturbating and nipple play. So about all I can think of as far as you're without sex for a week, being treated for either. And just to my point, we don't have concerns about chlamydia developing resistance to doxycycline. And speaking of doxycycline, I'll talk about it to Dr. Ritchie, right? Yes, Dr. Ritchie is going to talk about how to help prevent chlamydia. Okay. Next is syphilis. Syphilis is another STI, easily transmitted, but this STI is not in a specific site. Gonorrhea, chlamydia, or pick a site. Throat, penis, or rectum. And just for the point of making this comment, I'm not really talking that much about symptoms in women, because there aren't any women in the audience, but other than, and I'm looking right at you when I'm saying this, so online. So I didn't speak specifically about symptoms in them, but the symptoms are often the same as far as discharge with gonorrhea or no symptoms in women. And any STIs left untreated in women can cause severe problems, respiratory disease, problems with trying to get pregnant, problems of the cervix, of the fallopian tubes. And so that's why it's important for both men and women and their partners to be tested routinely. So, so with syphilis, it's important to get tested regularly, at least once a year. And I'll tell you why that's important in a minute, but you should always be tested annually or once a year for syphilis, because it too can cause some serious problems left untreated. Syphilis is not transmitted through a fluid, but it's transmitted through an open sore that someone has somewhere on their body. It can be in the mouth, on the tongue, on the genitals, around the anus, inside the anus. I've seen it on the tongue. These paint the sores or chancres, that's syphilitic chancres that's the point of entry. And that's also the point of transmission to another partner. So the sore is typically about 3 millimeters. It's typically round, which is about the size of your pupil. It's usually a round lesion. I've seen them in all kinds of shapes and forms, bigger, smaller. They are painless. So often there's not a big response to it. I've heard patients tell me like, oh, I thought that was a scratch from a tooth or an irritated hair follicle from shaving. I thought it was a canker sore, just a little stress ulcer on my lip or my tongue. And because they're not that painful, they don't just draw a whole lot of attention. That sore, that's the primary stage of syphilis. That's the first stage. After that sore heals, which typically heals fairly easily, usually in 2 to 4 weeks, that moves into the second stage of syphilis, and that is a rash. That's a rash on the body, typically from the waist up. It's a bright red rash. And then also you can get a rash on your palms or the bottom of the feet. They're sort of these dark, circular looking rashes. Everybody's taking off their shoes. No. They are can be on the palms or on the feet. That's the second stage of syphilis. The third stage of syphilis is when things get very serious and could actually move into neuro or ocular syphilis, which can cause blindness, hair loss, and then neurologic disorders. I've seen patients that couldn't walk in a straight line because they've had syphilis for such a long time. So I think my big point with syphilis is test, because it's elusive. Not everybody's always certain that that's syphilis. The only way you know is by getting a blood test. And the importance of testing every year is because it makes a difference in how you're treated. The treatments are typically done with injections of penicillin, but it makes the difference between whether you get one injection or if you get a weekly injection for 3 consecutive weeks. And if you've ever heard about the treatment for syphilis, everybody remembers it. It's a shot you'll never forget. A lot of medication, and it's given a big needle, and it's we are in a national shortage right now on penicillin, and the good thing is that there are alternative treatments for syphilis. It's not the preferred way, but it is effective, and it's than doxycycline. Doxycycline is just a wonderful antibiotic. And since it can cure syphilis, it can cure chlamydia, possibly some effect on gonorrhea. That's what makes it such a great antibiotic for preventing those infections. Syphilis. Oh, and then little bit about, I don't know if you're all familiar with DAP and our Orange Clinic there. The Orange Clinic is our sexual wellness clinic. We offer testing and on-site treatment for anyone. You do not have to be a client or a member of DAP. All you have to do is call up and make an appointment. We typically can get folks in same day or next day for testing. We help provide you treatment, and we take no money. We don't take insurance or any payment for the services in that clinic. So that's your brief overview on gonorrhea, chlamydia, and syphilis. Do you have some questions? Yes.
For all that information, you said something separate about is the monkeypox issue?
So interestingly, we have not seen any significant outbreaks of monkeypox since the fall of last year. Am I in the right year? Yeah, the fall of 2022 is when I think we saw the last sort of outbreak. There have been one or two isolated cases that I know of in Riverside. They're monitored closely. The patients that did test positive or have recently tested positive for monkeypox had been vaccinated. So we're not seeing a new uptick in that, but we're always, like I said, I'm on a couple sites to alert me to any new outbreaks or in our area, but we haven't been seeing that. Yeah.
And I just wanted to know, I thought azithromycin was given for some STI, but I forgot which one.
So we used to use azithromycin as a single dose for the treatment of chlamydia, but because it's such a short course, it didn't necessarily, wasn't always effective in treating chlamydia in the rectum. The rectal tissue is denser and takes a little more antibiotic and a little bit longer time, and they were worried about developing resistance to azithromycin, so we stopped using azithromycin for the treatment of chlamydia and only using doxycycline now. Yep.
Are there different strains in time to get doxycycline? Or is there not just standard 500 milligrams twice a day?
Right, so for the treatment of chlamydia is the 100 milligram capsules twice a day for 7 days. That's pretty standard.
You mentioned, I think, doxycycline also be used for prevention?
Yes. Yeah. So Dr. Ritchie's going to talk to you about using doxycycline as PEP. So the acronym for post-exposure prophylaxis. Most of the study, well, she's going to tell you all about it, but yeah, it's working.
Yeah, can you tell us the difference between the BDRL test receptors versus
Now RPR, right? So the other one was limited to one is a yes or a no, and then the next part of the test. So the test we use now, the RPR, is a reflex test. So the first part of the test is, are there antibodies to syphilis present? Yes or no? If yes, then it reflexes to can quantify it or give us a number or a ratio. If it's no, the test is over with. But the old VDRL was more of just a yes or a no. But we can quantify it now. And that number is important because once you've had syphilis, you almost, not everybody, but most people retain those antibodies for a lifetime. So they're useless antibodies. They can't protect you from getting syphilis again. You can get syphilis repeatedly. And that's why we use the reflex test now, so we can watch that number, watch it go up if it's a new infection, and watch it come down to know that you were effectively treated.
Can you tell us what's going on in the Coachella Valley as far as trends? Are these STIs pretty stable? Are they rising?
Yeah, so I get that question a lot in the clinic. People say, what do I need to be on the lookout for? It varies. And sometimes we'll see lots of chlamydia. Sometimes we'll see lots of syphilis. Sometimes we'll see lots of gonorrhea. The data lags. So I looked at Riverside County's data, and it looks really old because it was saying the last time I looked at it, gonorrhea had peaked. But I know right now, just from practice, chlamydia is peaking right now. And we also see big peaks of, and it will vary around big events like Coachella, the White Party, Gay Pride, all of these big events that bring thousands and thousands of people to town. It's a busy time. It's a busy time in our clinic after those kind of big events. But there's no one particular STI to be on the lookout for. I'm test for everything, always and frequently. If you're sexually active, you should be getting tested regularly. I appreciate it. Thank you, everyone. Oh, can I introduce Dr. Phyllis Ritchie?
Please do.
I would like to introduce Dr. Phyllis Ritchie. I've had the pleasure of working with her before, and she's going to tell you about her lovely clinic located right behind Del Taco. If you're driving through Del Taco and you're ordering, you're looking straight at her clinic. It is true.
It's pretty straightforward though.
Going?
So just use the arrows.
Okay, just like my computer.
There you go. There.
Okay, okay,
You have the
perfect.
three, you have the four, you have the three.
Okay. Hi, everybody. Can you hear me? Okay, great. So I'm Dr. Phyllis Ritchie. Oh, sorry. I am the CEO and founder of PS Test, which is no cost sexual health care right behind the Del Taco on Luring Drive. And we test and treat for gonorrhea, chlamydia, and syphilis, initiate PrEP, and push doxy-pep, which I'll be talking about. So I'm going to talk. So I'm doing. I'm following Trent, Broadus. I'm doing updates on. I'm doing updates on various STIs we've seen lately. So I'm going to run through mpox. I think that most of you are probably familiar with it. Maybe even saw part of this lecture before. But just to review, mpox is a rare disease caused by the mpox virus. It can cause a rash, and you can see the pictures up there. It may look like pimples, blisters, and you get a flu-like illness. It can spread to anyone via close personal, often skin-to-skin contact, direct contact with mpox rash, scabs, or body fluids from a person with mpox, touching objects, fabrics, clothing, bedding, towels, and surfaces that have been used by someone with the virus, and contact with respiratory secretions. Not as common, but it can happen. It can be spread during intimate sexual contact, including through oral, anal, and vaginal sex, or touching the genitals or anus of a person with the mpox virus, hugging, massaging, and kissing, prolonged face-to-face contact, touching fabrics and objects during sex that were used by a person with the mpox and have not been disinfected, such as bedding, towels, fetish gear, and sex toys. So preventing it, how do we prevent it? Having anonymous sex partners will increase your chances of exposure to mpox. So limiting your number of sex partners will obviously reduce the possibility of exposure. Enclosed spaces such as back rooms, saunas, sex clubs, or private and public sex parties where intimate, often anonymous sexual contact with multiple partners occurs will have a higher likelihood of spreading the virus. And another way, of course, is to get vaccinated, which is a two-part vaccination. Many people only got one part of vaccine. Diagnosis and treatment, diagnose with a PCR swab of the lesion. And there's some newer techniques. We were looking at collecting saliva and sending it off, and that seemed to be a really good technique of diagnosing mpox. Treatment, basically, the first thing you'd want to do is treat with the symptoms. So if you have a sore anal area, then sitz baths are really helpful. And then there's an antiviral called tecovirimat or TPOXX. So the update is breakthrough Mpox, and Trent kind of brushed on that. And it's occurred internationally in partially and fully vaccinated people. So we need to remain vigilant with our vaccination. So even if you only received one part of the vaccine series, if it was even a long time ago, it behooves you to get a second dose. The good news is that if you do get a breakthrough Mpox infection, it's much milder in patients that have had two shots. There have been some breakthroughs in people that have had both shots. There was a big outbreak, as Jeff was saying, in Chicago about six months ago, I'd say, at the oh gosh, I'm blanking on the name of the clinic, Howard Brown Clinic, and that was really eye-opening. So I believe that we're still looking at sewage water in Riverside County, and there hasn't been any uptick as of late. This is a picture of a patient of mine that had the Mpox. So I'm going to change the subject and talk about doxycycline post-exposure prophylaxis, which is a mouthful, so we'll call it DoxyPEP. That's what we're calling it. So DoxyPEP, in my opinion, it's an STI game changer. And many people think that it should be part of your sexual health wellness checkup. In fact, not even, I'm going to throw out sexual health, just wellness checkup. Anyone that's sexually active, they should have a discussion about DoxyPEP. And the reason it's a game changer, because if you take 200 milligrams, so it's a little different than the chlamydia dose. If you take 200 milligrams within 72 hours of condomless sex, you can reduce gonorrhea, chlamydia, and syphilis by 65%. This is something that's, you know, prevention. And you have to remember, I don't have a graph of it, unfortunately, but in Riverside County, chlamydia, gonorrhea, and syphilis have been on the rise since at least 2013. And then our little area, you know, of course, they're all three on the rise. So this is great. I mean, 65% is significant. In fact, the studies were stopped because the outcomes were so significant. It's recommended for cisgender males and transgender females. I can't quite understand why cisgender females aren't part of this. It's not unclear to me why. I don't know. I read something in the vaginal lining, but I don't know. But we're giving it to cisgender males and transgender females. We're offering it to them. So I'm going to talk about ringworm. This is a newer infection we need to talk about. And the reason we need to talk about it is because it's becoming resistant. And so ringworm, or Tinea corporis, it's a fungal infection caused by Trichophyton indotineae. Over the past 10 years, resistant cases in parts of Asia and Europe, and most recently in the USA, have been diagnosed. It can be severely itchy and painful and cover large parts of the body, and it's transmitted skin to skin contact. So it's very similar to monkeypox. Most recently in Paris, there were 13 resistant cases reported, and they were thought to be sexually transmitted in gay men because the rash appeared on the genitals, anus, butt, and face. So they were treated, I don't have that here, but they were treated with an antibiotic called ketoconazole. But it wasn't the regular antifungal, I'm sorry. It wasn't the regular antifungal that we usually use for ringworm. So it's something that we have to keep our eyes out for. So again, we have to be prepared and vigilant and look for the signs of ringworm. And this is what it looks like. I mean, it's just this round, red, angry looking lesion. And it's a fungus. It's not a worm, it's a fungus. And I think those are all my updates, short and sweet. Does anyone have any questions? Yeah.
Does your clinic offer MPAX? Does your clinic offer MPAX vaccination?
No, we don't, but the county still does, and the county's still offering the Mpox vaccine, and I mean, you just call them and find out where they're gonna be. They still have this mobile Mpox vaccine clinic. And so you can get it there really easily. I don't know if DAP is still offering it or not. Oh. Did Trent leave? Oh, I doubt DAP is still offering it. I'm not sure. I shouldn't say that, but I think the place to get it now at best bet would probably be Riverside County. And they have this mobile van that goes in Palm Springs, so it's pretty easy.
You can't get it at their location in Sunrise and Buffalo, so.
They never offered it there, Jeff. I don't know. I don't know. I don't know.
I thought I saw, in the weekly, newsletter from the Gay Center, that they still on occasions have times when they do it. I can't remember anything specific, but, it's worth checking their, that they make occasions when they do it.
It's certainly possible. I just had a coffee today with someone, David Salinas from the center, and they're getting ramped up to offer the new COVID vaccine. So I don't know, I'm not sure.
Is there option, for people who are allergic to doxycycline,
For doxypep?
for doxypep?
No. It's unusual. Maybe we shouldn't have this discussion here, but it's unusual to have, I have had patients with doxycycline allergies. It's unusual. I've kind of worked around them depending what they are, with Benadryl. So there are possibilities. In fact, I have one patient that really has a severe doxycycline allergy, very unusual, but it happens. And we tried it in the clinic first. Of course, we didn't have him do it. But what we did was we gave him some Benadryl and 50 milligrams in the clinic. He didn't drive himself there. He had someone else drive him because it makes you tired. And then watched him for about a half hour and then gave him doxycycline and he was fine. So that's how he handles his doxypep. Yeah. Depending what the allergy is.
If you got the early Mpox vaccine that when they were putting it, like the skin differently than when they put on the vaccine, is that effective or that's a long time ago? It's like probably having using no effect at this point.
So the question that's a really good question. And the bigger question, I'm just going to expand on your question, is how long do these vaccines last? And the answer is we don't know. And do we need another vaccine at some point? And the answer is probably, but we'll have to wait. It's kind of a wait and see because that
vaccination was effective in real one.
We don't know. There was a huge you were on that Zoom and we just don't know. It's all so new, we don't know. And unfortunately my suspicion is we'll wait for another outbreak. I hate to say that, but see and decide whether or not we need to vaccinate again. At the time of that outbreak in Chicago, and now it's happened internationally, the thought was, well, you don't really need another vaccine because it was mild in people that got 2 shots, even in the intradermal dose. The breakthroughs were mild. In the people that got 1 dose, they were severe. So I do recommend getting the 2nd dose, whichever one you got. But we don't know if one's better than the other, how long either immunity lasts. We just don't know the answer to that.
The second dose, like you have that, one more for the second, or would be
No, you just need 1 more. Yeah, we learned that with our hepatitis vaccines, where for instance, hepatitis A is two shots. And a lot of patients forgot to come back 6 months later. So you can still get one a long ways away from that. You don't have to start all over again. Yes. Yes. Oh yeah, sorry.
The purpose of the ringworm discussion is because it's becoming more prevalent, or
Yeah.
also what happens if you had it, does it, and you don't treat it, does it go away and it stays in your body? Or what would be the long-term effects of not treating bullying? Thank you.
Well, you know, we're seeing more of it, and we're seeing more resistance in gay men and other men who have sex with men. We've seen some in the United States resistant cases. I don't think those were in gay men, but they were resistant cases. But this Paris one in gay men opened our eyes, and the reason we're worried about it was because the Mpox was happening in Africa for a very long time, and that was Africa. You know, this is the United States. What does that have to do with us? And boom, we got the Mpox outbreak here. So that's why we're worried. We're worried that, you know, it'll come here. It's uncomfortable. The long-term effects is it's uncomfortable. It'll stay there because if you don't treat a fungus, it won't resolve on its own. Think of athlete's foot, which is a fungus. It does not resolve on its own. So we'd want to treat it, and it's red, it's itchy, it's uncomfortable. So normally you treat it with normally you can treat it with one of the cream antifungals, and it usually responds, but we're going to the oral antifungals now because of this resistance, and that seems to work better. Yes.
Thank you, Dr. Ritchie. Also, it's not in your presentation, but could you tell us more about Chagall? Is that what it's called? Because
Shigella?
yeah,
Shigella?
Because I had it last summer, and then my friend in March was admitted into Eisenhower, and I guess it was all over his entire body. He ended up dying, not because of that, but I know it's prevalent, and they were tracking me, so I had to have a long discussion with the county of Riverside, and apparently at that time there was a circle of it going around Palm Springs, but is there a way to explain a little more about that?
Yeah, I mean, Shigella can be sexually transmitted. Doesn't have to be sexually transmitted. You can get it from food sources as well. But it's a severe infection, really dysenteric diarrhea, and there's resistance to that as well. I had a patient that had traveled to Mexico who came back with Shigella, and you know, he had a resistant case. You can get it sexually, you can get it through sex toys that aren't cleaned properly. It can be oral anal, so meaning, you know, if you have oral sex of the butt area, you can get it. But you can also get it from food sources as well. But it's becoming more and more resistant. You know, just dysenteric. Yeah, dysenteric. Bacterial. Shigella is the name of the bacteria.
With all the different vaccines, do you recommend getting one visit and getting as many as you
No,
can?
no, no. My dad just asked me that question. I don't. So I don't even. I know that the CDC is recommending now flu and COVID together. I say wait 2 weeks, and I stick with that. I think that you're, you know, I've read a lot about it, and I think, you know, the feeling is that your body needs to develop antibodies to one or the other, and I really strongly believe to wait 2 weeks. If you're traveling, it's hard, and you need a bunch of different vaccines, but I recommend to wait 2 weeks between COVID and flu for sure. Anyone want to ask about RSV and should you get it? I do have an opinion on that too. My opinion is I just read all about that, and it's weird. It's a weird recommendation. The FDA said they don't say you should get it if you're over 60. They said you may get it if you're over 60. A lot of experts think it hasn't been looked at long enough. You need to talk about it with your doctor. It's not strongly recommended, even though everyone, it's out there and everyone, you should get it. It's traditionally in younger people. They feel if you're immunocompromised, if you're over 60, it's a little stronger. But the behind the scenes of that RSV vaccine is they probably should have waited at least another season before recommending it. There were 3 people after they got the RSV vaccine that developed Guillain-Barré syndrome, which is a paralysis. And, maybe it wasn't due to the vaccine, but it seems suspicious to me because Guillain-Barré can be associated with vaccines. So I'm not, well, I'm sure you'll be fine. No, I'm sure you'll be fine. I'm sure everybody will be fine if you get it. But I do think you need to talk to your doctor about getting it before you get it. And that is a recommendation, just talk to your doctor about it.
With Doxy in San Francisco, they're doing a lot of things with Doxy Prep. The same idea, except you take a prophylactically, like Truvada or HIV.
Yeah.
Do you have opinions or?
Yeah, I have opinions about everything. So I loved Dr. Steve Scheibel. He was a wonderful doctor, a good friend, and I miss him every day. And he was a big proponent of Doxy Prep, and I really like Doxy Prep in certain situations because I'm also an infectious disease specialist, so I have 2 different hats. Doxy Prep, let's go back to that. Very little chance of resistance because you're taking it intermittently. So there's actually been no resistance yet with Doxy Prep. Doxy Prep probably, so he would use Doxy Prep a lot, and that was before studies of Doxy Prep. That was, so I it had merit and it was valid and a great idea. But nowadays with Doxy Prep, I push that more because I like it. Doxy Prep we're giving to people that are sexually active 5 or 6 times a week, or sex workers we're giving Doxy Prep because it just doesn't make sense to take it within 72 hours of condom sex. That's just ridiculous. So we do give out Doxy Prep, but there is more of a chance of resistance. You have to kind of balance that and weigh that. And we talk to patients about that as well. But so we kind of give out Doxy Prep in different ways. It's also good.
Trent left already. I'm surprised he didn't say that they offer Doxy Pep at DAP because I'm actually a Doxy Pep patient.
Yeah. Yeah, no, I know they offer it. They offer it at DAP. Yeah, for sure. Yeah, I think that most clinics now offer it.
So with Doxy Prep and someone that was sexually active a lot, would they just be on it full time?
For Doxy Prep, so as we were talking before, Doxy Prep's different from Doxy Pep. Doxy Prep, so if you're a sex worker or having sex, 5 or 6 or 7 times a week, we'll give you Doxy Prep. That's 100 milligrams once a day. 100 milligrams once a day. You have to keep in mind there are side effects with doxycycline. Doxycycline is a great antibiotic, even for bronchitis. I've prescribed doxycycline, but one of the main, so you have to remember that you need, I recommend taking food with it. I also recommend to be cognizant of medication you're on. For instance, if you're taking Tums, that decreases the absorption of doxycycline because there's calcium. You don't want to take anything with calcium a half hour before or half hour after. It decreases the absorption of doxycycline. And we've had patients that came back with an STI. Well, you have to remember also it's only 65% effective. There's still that 35% chance. But we've had patients that came back and said, oh, I was on Tums, and that could have been the etiology of them getting the gonorrhea.
And with other antibiotics also with calcium?
Other antibiotics? Yeah. Doxycycline is a big one. Yeah. And then the other big side effect, particularly here in Palm Springs, is photosensitivity, and you get horrible sunburns. So those are other things you have to think about with the daily doxycycline or even in the doxypep.
Well, like gonorrhea has gotten enough attention, so I'm gonna ask about the meningitis B vaccination.
Yes, thank you. I should have included that. The meningitis B vaccine has been shown to help prevent gonorrhea. I think it's worthwhile. Your insurance company will not pay for it. And it's expensive, but I would, I would definitely recommend it. That's such a great point. I should have had that in my lecture. I apologize. The other thing about gonorrhea you have to remember, because I know Trent was saying that it can be symptomless, which is absolutely true. It can be, especially in the throat. You just don't know you have it. But the other thing you have to remember is that it can disseminate in your body and cause a monoarticular or one joint infection. So, and this is happening more and more often these days, where patients come into the ER and their knee is swollen and they were sexually active, and it actually is gonorrhea. So I like the meningitis vaccine. I think it's worthwhile. It's just that the county's not giving it out for free, unfortunately, and your insurance probably won't pay for it, and it's expensive. I think it's about $120 or $150, something like that. Just one. I think just one. Yeah.
Difference between the C and the B. Are you normally getting the C?
We're normally getting we're normally getting, because there have been outbreaks of actually meningitis in gay men and other men who have sex with men, and we are allowed to get the C W and 135, and that your insurance will pay for that one. And there were outbreaks in New York, Palm Springs, so there are two different meningitis vaccines. This is B, meningitis B.
Would you expand on what you're saying about the meningitis vaccine? You're saying
it can prevent gonorrhea. It can prevent gonorrhea. So we have to remember it's meningococcal gonorrhea and meningococcal meningitis. They're both from the same family. And there's two different meningitis vaccines, and the B can prevent gonorrhea. I'm trying to think of the percentage. I think about the same percentage. I think it's about 65 or 70%. The county is not giving out CDPH. The California Department of Public Health has to approve it, and they haven't, and blah, blah, blah. We've had discussions with them. We're not going to give it out.
the vaccine? I just never heard that it was effective.
Yeah. Yeah. I should have put it in my lecture.
Got a question on meningitis, which meant that I've known two people that have gotten it, and by the time, before they knew they had it, they were dead. They had a headache, really bad headache the next day, they don't answer the phone, and the sister goes and they're dead on the floor in the living room. And then with a young man, friend of mine's son, who's early 20s, he died mysteriously. It took him 4 months after an autopsy to figure out what had happened. So is that typical meningitis?
Yeah. Yeah, there's all different causes of meningitis. I wouldn't know what kind he had, but there's meningococcal, there's pneumococcal. Don't forget to get your pneumonia shots if you haven't got them. So there is a vaccine for the meningococcal meningitis, and actually your insurance company will pay for it, and you actually can ask your doctor, your regular doctor, for it, and they can either give it to you or send you to the pharmacy. But there's two different types. The meningococcal meningitis vaccine that covers ACYW135. The normal one, to say that, I'm going to New York, they'll give that one to you. that you want the vaccine that will prevent a meningitis, and your doctor will give you that. Or the pharmacy will, that you won't have to pay for. And then the other one that may prevent gonorrhea, that one you'd have to pay for. But you get it at your pharmacy. Yeah, that's true.
Dr. Ritchie, I'm just curious, what is the bodily reaction that you wouldn't know that you had gonorrhea in your throat, but it would burn when you urinate? You know, like what makes it burn when you pee, but why wouldn't you have a sore throat? I guess it's what
Yeah, but you know, I do have patients that have sore throats, but not often. And that's a really good question. I don't know. I'd have to look into that. I'm not sure. There's drainage and there's burning when you urinate, but I don't know. I've never been asked that. That's a great question.
But for women that urinate, it doesn't burn, but for men, it would burn.
Oh no, it burns for the whole gamut. Yeah, yeah. Chlamydia is the one that's more silent. Yeah, for everybody. So.
My favorite drag name is chlamydia burns.
Any other questions? Yeah, of course. Thank you. Thanks for having me. That was fun. I haven't done an in-person lecture since before COVID, so this is great.
It's always a good time to talk about sex.
Yeah.
So terrific. Thank you, everyone. We'll see you next month. A couple of other announcements that I forgot to make earlier. In November, the center is going to be hosting a program on the AIDS quilt, and they're going to bring down Gert McMullen, who was kind of the Betsy Ross of the AIDS quilt back in the day. Cleve Jones gets all the attention, but she was one of the drivers behind the quilt happening, and she's still involved with it. So we're really excited to have her come down, and we're making some panels. If somebody wants to make a panel or show a panel of someone they know and love, let me know. We can put you in touch with the folks at the center. We're working on creating panels for Timothy Ray Brown and for Dr. Scheibel, because it's going to be November 15th at the Mizell Center. I don't know if that's gone out yet. We haven't gotten the information from them. The AIDS quilt events at Mizell Senior Center. And then, of course, coming up on World AIDS Day, speaking of Timothy Ray Brown, we're going to be placing a star for him on our Walk of Stars. And that'll be on Museum Way, not on Palm Canyon, but on Museum Way, right in front of the future location of the AIDS Memorial Sculpture. So that'll be happening in the afternoon. And then at 4:30, we'll have a program here with some cure researchers from the RID Collaboratory that we partner with, as well as the California Institute for Regenerative Medicine that does stem cell research. And our own Paul Edmonds is going to speak as well about his experience getting cured. So that'll be December 1st, World AIDS Day. So stay tuned, and we'll let you know more as everything gets finalized. Okay, yeah, the save the date has gone out, and it'll be in the upcoming newsletter on the website. Yeah, that's right. Stephen has already got the registration up, so register early, and we hope to see you there. So thank you again. Oh, and one other teaser for the Positive Life in January. We just confirmed today that we'll be showing the documentary that was recently released on the founding of AIDS Project Los Angeles. Ron Sylvester is a local part-time resident of Palm Springs, one of our former board members. He's one of the producers and on the board of APLA. So this will be showing here at the Camelot during Cinema Diverse on September 24th. And then we've got, they've promised to give us a private screening for our January program on January 2nd. And we're trying to get a couple of the producers to come and talk about the history and the making of the documentary. So stay tuned for that. Great. Thank you, everyone. Good to see you all. Have a great evening.